Hello and welcome to this new session in our Bone Matter series. Today we're talking about recovering from a broken hip. The medical term that you may have heard for this is hip fracture, and they're both the same thing. Now, you may well be listening because you or someone you know has just had a hip fracture, may already be in hospital, or perhaps some way through the experience and just needing more information. You may have osteoporosis and have had fractures before, or this may be a first one for you. And either way, our aim is to increase your understanding, really to help you or someone close to you fill in the information gaps for the best possible recovery and getting back, we hope, to a good quality of life. So I'm really lucky today to have experts in the field joining me. Both of them are academics involved in research, and also working in clinical practice as well. And they're going to share a few slides with you, and then we're going to be discussing common questions and issues. So welcome to you both. And let's start by me asking you to introduce yourself. Perhaps Celia, you could go first.
Yes, so thanks very much, Sarah. So my name's Professor Celia Gregson. I'm a geriatrician and orthogeriatrician. So what that means is I'm a specialist who works in a hospital as a physician, looking after older people and particularly older people who have had fractures. I also am an academic, as Sarah said. I'm a Professor of Clinical Epidemiology. So I do my clinical work in a hospital, the Royal United Hospital in Bath, and I do my academic research work at the University of Bristol. Thank you.
Thank you. So over to you now, Katie.
Hello, so my name is Dr. Katie Sheehan. I'm a physiotherapist and a health services researcher based at King's College in London. My research focuses on improving the care that people receive after they break a hip.
Perfect. Thank you very much, and thanks for being here. Welcome, really. Let's begin then. Celia, can I ask you to, I suppose, set the scene and tell us all about having a broken hip and really what happens when you go into hospital for an operation to mend it and the important things that people need to know. So I'm over to you, and we're going to see a few slides.
So thank you very much, Sarah, for that. So hopefully you can see my slides. So I'm just going to talk about recovery after a hip fracture, as you suggested. So just in terms of a hip fracture, so these words get used: fracture, crack, break. They're all the same thing. When people say, oh, they've only cracked it, actually they have fractured it or they have broken it. They're the same things. So hip fracture actually relates to a break, a crack, or a fracture in the top part of the femur. So your femur is the bone that runs through your thigh. So it's a really big bone in the body. And if it breaks towards the top end, so you can see here, I'm showing you, you can either have a break through the neck of the femur or through this thick bit here, or a little bit further down. So the femur comes up the thigh, and at the top, you've got this ball at the top of it, and that fits into your socket of your pelvis. So it's what's called a ball and socket joint. And so, as I say, you can crack it in a number of different places. And according to where you break it, that determines the type of operation you need in order to fix it. So, for example, if you were to experience a break through this thicker bit of bone here, you can see the break line, the fracture line there, it corresponds to this line here, then you actually need what's called a dynamic hip screw. And that's where the surgeons put a plate on the outside of the thigh bone here. They screw it in, as you see here with these 4 screws. And then you have this very large screw that goes across the fracture line and secures the 2 bits of bones together with this screw head that sits in the ball of the femur. Now, it's different if, for example, your break is across the neck of the femur, the fractured neck of femur. In that instance, you actually have to take the ball off the femur because there's no longer any blood supply to the ball of the femur because you've got a crack through this particular bit of the bone. And so the ball gets removed and it gets replaced, you can see here, with this metal equivalent of a ball. And that metal ball is attached through a metal stem that slots into the top of the femur. And this is called a half hip replacement. We call it a hemiarthroplasty, hemi being half. So you can see that actually the type of fracture determines the type of operation. And the operations are all a little bit different, and that means people's recovery after a broken hip is a bit different from one another. There's not one general rule. So in terms of some facts and figures about hip fractures, there are approximately 70,000 people who experience a hip fracture every year in the UK, and they most commonly occur after a trip, a slip or a fall. They're all really falls, all of those things, but it's a relatively low impact injury from standing height onto a surface, be that a concrete floor or whatever, but it's a relatively low impact injury, and you end up breaking one of the big bones in your body, your femur. The average age of people who break their hips in the UK is 83. So it is generally an older population who experience hip fractures. Importantly, a quarter of all hip fractures occur in men. So yes, it is largely women who experience hip fractures, but actually there's quite a large number of men who also experience broken hips every year. And it is, as I say, a big bone that you're breaking. It's a significant injury, and people spend time in hospital recovering from that. And we tend to say that most people will be in hospital at least a week. And then beyond that, it rather depends on who you are, what your other medical issues are, and the type of operation that you've had. So it's also worth knowing that hip fractures actually are very costly to the NHS because they require complicated care from lots of different specialists, and that ends up costing money. And so the NHS spends more than £2 billion every year on delivering hip fracture care just in hospitals. So what should you expect when you go into hospital with a hip fracture? Well, the first thing to say is it's an emergency procedure. And my patients always say, oh, I came in unexpectedly, I haven't brought the right things with me. And that is the case for any emergency admission. It is always unplanned, and all of a sudden life changes quite a lot and you find yourself in a hospital bed. People come into hospital with a hip fracture and they've often got other medical problems that have been an issue in the past, or they're currently being managed. So as a geriatrician, as an orthogeriatrician, it's important that I manage not just a person with a hip fracture, but actually all of their other medical conditions, and make sure that they are optimized for an operation. So for example, if somebody has diabetes, they may well need their medicines changing in order to maintain good blood sugar control while they're in hospital. You'll also find that when you're in hospital, doctors want to give you medicines in order to try and prevent further osteoporotic fragility fractures from occurring. So if you've had a hip fracture, that's an osteoporotic fragility fracture, and it's important to consider whether medicines are appropriate in order to try and reduce somebody's risk of having a further fracture in the future. So that's often discussed and attended to while somebody's in hospital. So you'll see that there's a box here called delirium, and delirium is a fluctuating confusional state. So that's where sometimes some people can be quite alert in the morning, but in the afternoon they may become quite disorientated and not necessarily know where they are. It's quite common in the context of hip fracture, so it can affect up to a third of people who suffer a hip fracture at some point during their admission. It means that people might find it quite difficult to concentrate and to think things through and to remember where they are at every moment of the day. It's more common in people who have a background history of a dementia, but it can occur in people who haven't ever been diagnosed with a dementia before. And it's important that families are aware that this might happen to their family member who's been admitted with a hip fracture, because if you're not aware that this might occur, it can be quite distressing for a family to see this of their relative for the first time. And it's also important to let patients also know that this might happen because they can sometimes feel quite out of control when they're in hospital as a consequence of delirium. There are different things that we can do in order to reduce the risk of a patient experiencing delirium, and that's certainly something that doctors and nurses and the wider multidisciplinary team consider quite carefully. But some simple things you can do as a relative are, for example, bring in a little table clock for your relatives so that they always can see what time of day it is and help reorientate. In terms of eating and drinking, what you'll find is that when you're admitted with a hip fracture, people will stop you eating and drinking anything. And in fact, we have to not let people eat and drink from the night before they're due to have an operation performed. And because the vast majority of people do have an operation to fix a broken hip, the vast majority of people will be stopped from eating and drinking. The reason for that is that when you then have an anaesthetic, your body can be sedated and it doesn't take care of what should go down the right tube. So it's possible that if your tummy is full of food or drink, that can come up and then down your windpipe and into your lungs and cause problems. And so anaesthetists like the stomach to be empty, and that's why they stop you from eating and drinking before an operation. As soon as you've had your operation, you should be able to get back to eating and drinking. And in fact, after a hip fracture, it's really important actually you eat and drink quite well, more than you normally would. And we put a lot of emphasis on eating protein and calories. So your body needs much more energy than it normally does when it's recovering from a broken hip, because your body has to heal, and the body is in that sort of overdrive after recovering from a broken hip. So we actually give high calorie protein drinks to a lot of patients in order for them to get a boost even over and above 3 meals a day. And those protein drinks are important because bone and muscle are made of protein. And you need to eat and drink protein in order for your body to have enough material to work with. Then I've also put here a box about urinary catheters. So this is a tube, a little plastic tube that goes into the bladder and collects urine. So you don't have to get onto a toilet in order to pass urine. Now, not everybody gets a urinary catheter. But quite a lot of people do, and they can go in, be put in by the nursing staff either before an operation, if it's difficult to get onto a bedpan, or they can go in during the operation itself in order to avoid urine coming out of the bladder and going into the wrong place during surgery. We like to get catheters out as soon as is possible because there is a risk of infection whilst ever you have essentially a bit of plastic in the bladder. And I've also put here a box around the multidisciplinary team because one of the things that you experience as a patient with a broken hip is that you see a lot of members of staff, all in different uniforms. And it can be quite overwhelming, just the number of specialists who you have to interact with. There are obviously the nursing staff on the ward all of the time, but you will also see a surgeon, often more than one surgeon, anaesthetists, physicians such as me, so geriatricians and junior doctors who work within the teams, physiotherapists, occupational therapists, often discharge coordinators. You may see memory specialists, swallow specialists, and so on. So there are really a number of different people who you may interact with whilst in the hospital environment. So what makes a difference to you getting back on your feet after a broken hip? So the first thing to say is pain relief is obviously really important and has come a long way in more recent years. And there's now a move to use much more in the way of nerve injections when people first come into hospital. So these are called femoral nerve blocks. And what the team do is they inject a little bit of local anaesthetic into the groin around the nerve that supplies the hip, and it then numbs that nerve. And actually that's very effective and means that people don't have to take so many tablets that can make them feel quite nauseated, quite sick, as one of the side effects. So nerve blocks are a very good thing. prompt surgery is really key. So the sooner you obviously have your hip fixed, the sooner you can get back onto your hip and walking again. And so we try to get people to theatre to have their operation within a day or so of coming into hospital with a broken hip. So that's one of the reasons why things happen pretty fast when you first come into hospital. Good nutrition, I've already said this, and especially protein is really important to recovery. There's quite a lot of research that shows that if you do have an increased protein and calorie intake whilst in hospital, then you can sometimes stay in hospital a shorter period of time, and you're less likely to get complications of infection. I've put here also getting out of bed as soon as possible. So the hip fix that the surgeons do is designed to be able to take all of your weight straight away in the majority of cases. There's the odd type of surgery where one doesn't do that, but most hip fixations, you can put all of your weight on it straight away, and it's good if you do, because if you keep moving your muscles, you won't lose your muscles. So that's why we want to get people out of bed either the day of the operation or the day after the operation. And that leads on to regular physiotherapy, and I'm obviously best to hand over to Katie on that point. But just to highlight that there's a really useful book that's been produced by the Royal College of Physicians, who run what's called the National Hip Fracture Database. The leaflet's called Your Hip Fracture, and it's given to all patients in the UK who are admitted with a broken hip. And if you want to find it online, then at the end of this session, we'll show you the link as to where to download that. And with that, I will stop. Thank you very much.
Thank you, Celia. So much information and lots of practical things too, which I think will be incredibly useful. So thanks for that. So it's over to you now, Katie, to talk about getting better after the operation, what we call rehabilitation, what you need to know and think about.
Hopefully you can see my screen. So thank you. I'm going to speak a little bit about what we mean by recovery, what recovery can look like after hip fracture, the support that you'll have to engage in this recovery process, and then a little bit on the role of carers in supporting recovery after hip fracture. So what do we mean by recovery? So the word itself is quite abstract, and one person might answer the question quite differently to another. In the past, if you asked a surgeon, they might have said it's when the bone is healed, and a physiotherapist might have said it's when somebody can walk the way they used to walk before they broke their hip. But thankfully, times have moved on, and there's an acknowledgement now that recovery really should be described by the person who has broken their hip. So across a lot of studies, researchers interviewed over 270 people who'd broken their hip and asked them what recovery meant to them. And unsurprisingly, actually, people describe recovery very similarly. But what is interesting is that how it's described changes depending on when you ask somebody. So in the very early stages, most people will just want to get home, and they'll define it by saying, I just want to get home safely, to leave the hospital as quickly as possible. A little bit further along the recovery journey, we'll start to hear things like people saying, I want to get back to normal. And this may be described usually in terms of day-to-day activities. So, be it housework or shopping, gardening, as well as more social activities. So meeting up with family, looking after the grandkids, going for lunch, and other activities like that. But at the heart of all of this is really about maintaining independence, and getting back to the level of independence that people had before they broke their hip. Now, early thoughts about what you want for your recovery can be really helpful when planning your care. But it can be important to recognise that having these conversations can be quite distressing after breaking your hip. We know that the possibility of becoming more dependent on others is a real source of anxiety for a lot of people after they've broken their hip. And we know that these anxieties are particularly felt by those who maybe weren't as able to get around before they broke their hip, or who have other conditions, and also for those who are perhaps looking after their husband or their wife themselves. What may help is that we also know that as your recovery progresses, the anxieties do ease as your independence in the day-to-day activities that are important to you begin to return. So that brings us on to the next question. What does recovery look like after hip fracture? And what most people want to know is how long is it going to take? And that's a really difficult question to answer. Recovery is individual and different people are going to be affected in different ways. The key message really is that recovery takes time. You've had an injury and you've had a pretty big surgery to fix it. There's a lot of implications of this, not just the physical implications, but there's also the psychological implications, the cognitive implications, and social, all of which require some time. So as an example, if you were to say that recovery to you is being able to go out for lunch with your family again. So this activity requires the physical ability to get up, to get dressed and showered, maybe go downstairs, and then the physical ability and the confidence to go outside of your home, maybe where you had your fall beforehand. Maybe if you have to take a bus, the cognitive ability to know which bus to take, when to get off the bus, and then after all of that, be able to socially engage with your family at the lunch. So it's possible for all this to come back. It's just going to take a little bit of time for each of these aspects. And it's really important that you acknowledge this, that it's going to take time, but also that the people around you are aware also and that they acknowledge it. It can help to overcome feelings of frustration, that it's taking a little bit longer to get back to normal, and also feelings of despair that recovery may never happen. Now, I've not really addressed the question of how long is it going to take, as it's not a one-size-fits-all, but to try and put some numbers on this. So the graph here are from a study that was done a while ago for 700 older adults who broke their hip, and they were followed for 2 years, and measurements of different aspects of recovery were made at regular intervals. So the activities are listed along the left of the graph. Across the bottom is the recovery time in months. And then the black bars represent the average time it took to recover each of these activities. So the activity labels in some parts are a little bit abstract. So for the ones that aren't 100% clear, leg activities are things like climbing stairs and getting off the toilet or off a chair that doesn't have arms, walking a block, putting on trousers, socks, shoes, those sorts of activities. The daily activities cover things from housework and shopping to managing money, taking medication, and getting places outside of walking distance, so maybe using public transport. And then the arm activities is another one that's not 100% clear. That's things like putting on a shirt or a blouse, using buttons, feeding and grooming as well. So you can see from the graphs that depressive symptoms or low mood, as well as those arm activities that I mentioned, and also cognitive changes such as delirium that Celia mentioned, recovered for most people by around 4 months. Whereas the leg activities and the daily activities and social activities took almost a year to recover for most people. Now, to remember, these black bars represent the average. So some people will take a little bit less time and some people will take a little bit more time, but it gives you a sense of how long it'll take most people. So given that different activities take different amounts of time to recover, many of the people interviewed about their recovery did acknowledge that normal might look a little bit different and that it might not be possible to do everything they did before they broke their hip, and that this was okay as long as they were able to preserve a sense of independence. So you are not expected to be able to visualize what your new normal may look like, but it's worth keeping it in mind that you might get back to doing the things that you enjoy doing, but you just might do them in a slightly different way. It's a really personal journey to go on, but one that you can gain support from the healthcare professionals that you're interacting with, but also from friends and family members too. The key thing is to try and do as much for yourself that you can safely. And for friends and family members, it's key to encourage independence in activities as much as possible, even if it takes a little bit longer than you would do it. And to give positive feedback to people once an activity is achieved. It can really help. And avoiding any activities is really linked to poorer recovery. So trying to do as much as you can for yourself safely across your recovery journey is really important. So what care will support your recovery within the NHS? So in the hospital, as Celia mentioned, you might be quite surprised that you're getting up out of bed quite so quickly after your surgery. But getting up this early, so on the day of or day after your surgery, is really linked to getting home safely quicker, and it's also linked to recovering your walking ability, amongst other outcomes as well. So there's good research for why we're arriving at your bedside quite so early and asking you to get out of bed. The first time you get out of bed, it'll mostly be with the physiotherapist, but sometimes it could be a member of the nursing staff or also occupational therapy. For the remainder of the time in hospital, the Chartered Society of Physiotherapists recommends that you receive daily physiotherapy that adds up to at least 2 hours in that first 7 days after your surgery. If you're in hospital for longer than 7 days, the recommendation is that you get 2 hours per week in the subsequent weeks that you're in hospital. The time that you have with physiotherapy and other members of the team, so perhaps occupational therapy, will be based on recovery goals that you set with the team. So it'll be very tailored and individual to you based on your previous abilities and what you want to get out of your rehabilitation for your recovery journey. So the goals might include your end goal. So from our previous example, maybe getting back to being able to go to lunch with your family. But it'll also include shorter term goals, and these might be a little bit more function based. So it might be something like being able to walk to the toilet by yourself with 2 crutches in 2 days' time. The other big thing that will happen during your hospital stay is planning for going home, or discharge planning. And it might seem a little bit strange to be having conversations about going home again quite so quickly after your surgery, but it's really just to allow enough time to prepare appropriately so that when you go home, you're supported as best as possible. So the plan might include going to another hospital ward, to another hospital, or to a rehabilitation hospital for a little while before going home, depending on what's available in the area that you've had your surgery. You're not going to be sent home or to the next stage of rehabilitation if the team doesn't think it's safe for you to do so. So this planning will include things such as like a discussion with the occupational therapist about your home or the care home environment, and support available to you to make sure that you can manage day-to-day activities safely. An assessment of your ability to wash, to dress, to get on and off a toilet, and also to walk, maybe with a new walking aid, such as a frame or crutches or a walking stick. Also to go up and down stairs, if that's something that you have at home, to make sure you can go in and out of your home, or you can go upstairs to your bedroom or bathroom as needed. And also some discussion around any concerns that you might have about, your ability to do shopping or cooking, or other kind of aspects of your daily life that might be challenging in the early phase after you go home. Once you're ready to leave the hospital, the rehabilitation that you receive unfortunately differs quite a lot from one region to another. So again, that Chartered Society of Physiotherapists recommends that everybody moving from hospital to the next phase of rehabilitation is seen by their new rehabilitation team within 72 hours. And this is the aim, but it's not always achieved. So before you leave the hospital, it's a really good idea to ask what the current waiting time is for the next phase of your rehabilitation, to give you a little bit of a sense of what you need to plan for, and maybe to ask what you can do while you're waiting to be seen. In terms of how much rehabilitation input you'll get in the community, again, it's going to unfortunately vary depending on where you live and how those services are funded. We did recently interview physiotherapists based in the community across England, and most indicated that the level of input is going to be very individual. It's going to depend on the person, the service capacity, and also the rehabilitation options that are available. But very few services would keep you on for one-to-one sessions for longer than 12 weeks with a physiotherapist or an occupational therapist. Some services will have group classes that would be available after this time, but some services don't have that option in place. So it's really good to have a discussion with the physiotherapist or the occupational therapist that you're working with to see, when these one-to-one visits end, what can I do to continue my recovery journey? So what services are available for me locally, maybe through the charity sector, or other services that can carry on the gains that you've made with physiotherapy and occupational therapy. What actually takes place during your one-to-one sessions, again, is going to vary depending on where you're at and what your goals are. It could be performing daily activities, so getting up and out of a chair, moving around inside your home, practicing going in and out of your home if that's a particularly challenging space to move in and out of, or it could be walking outside. So it'll really depend on your abilities and what your goals are for that time with the team. Now, in the last slide, I mentioned the Chartered Society of Physiotherapy a couple of times and their recommendations. More information is available on these through the report that was published a few years ago. Now, these are recommendations, and how often they're met in England was measured a few years ago. And from this image, you can see that 68% of people got out of bed on the day after their surgery, which that proportion has improved. That on average, people received 2 hours of physiotherapy in the first week. 1 in 5 started their rehabilitation within 1 week of going home, and 1 in 5 were fortunate to get physiotherapy on 4 or more days in that first week after going home. It also highlights that not everybody gets physiotherapy every day when they're in hospital in that first week, that some community teams don't actually get a handover from the hospital team. So they might have to ask you some of the same questions again in order to get a good sense of where you're at, and so that they can really tailor that care to help you with your recovery as much as possible. And that also the average wait time for physiotherapy when the report was done, which again was a few years ago, was 15 days. So there might be a gap between when you leave the hospital and when you're seen in the community. So I hope by this point, if you're a family member, friend of a carer, or somebody who's broken their hip, you have some ideas of what you can do to help. But I think one of the most important things to reiterate here is that recovery takes time, and it's really important that if you're looking after somebody or working with somebody who's broken their hip, that you also look after yourself. Don't be afraid to ask for help. You can talk to the team in the hospital or the team in the community about any concerns that you may have, or indeed your GP if that services have ended. It could be really challenging trying to care for somebody while also managing work and children and other responsibilities that you might have. So do be kind to yourself. Look to forums to speak to other people who maybe have supported somebody who's broken their hip to see whether you can get any tips or tricks that have worked for them. If you are able, it can be really helpful to be engaged in care decisions or care discussions so that the healthcare team has got a good picture and the most accurate information about the person who's broken their hip, but also that you have the opportunity to ask any questions that you may have or clarifications for anything you don't understand, and that your concerns are heard by the healthcare team when you have the opportunity to interact with them. It'll also give you a sense of how to navigate the complex system that you've entered into, and make the most of the resources that are available to you. There's also a role for supporting the person who's broken their hip. So encouragement and feedback is hugely important. We know this, and it's really very important from people that you trust. So they're going to trust you. So it's really important for you to positively reinforce that recovery takes time, but that they're doing really well. And maybe going for walks with them, engaging with the exercise program that they've been given, and encouraging people to do as much as they can for themselves on their recovery journey. So to summarize the key points, how you will describe recovery will likely change over time, but it might end up being a new normal that allows you to retain a level of independence, albeit in a different way of life before you broke your hip. It's important to acknowledge that recovery takes time, to avoid feelings of frustration or despair at slow progress. Rehabilitation offered through the NHS can vary depending on where you live. It's good to ask what you can expect when you leave the hospital and how long you're likely going to wait. When you're getting rehabilitation in the community, ask what services you can continue with once it ends. Try to do as much as you can safely for yourself, and for carers to look after yourself. As time allows, engage in plans for care and also provide encouragement. So I will leave it there.
Thank you, Katie. That was absolutely brilliant, really comprehensive and really thoughtful. And I'm sure everybody listening will just feel a whole lot more informed, but also supported, because I think what you recognise is this can be a challenging time for everyone involved, but also some really good positive messages I felt there about with time, things will get better and good care and good good care from everyone, so that's great. So let's move on to the last part of the session and really go through some of the further questions that we get asked. I've got a huge list, but you've actually answered lots of the questions already, so I'm going to kind of pick through it a bit and ask you both to add in any thoughts or comments. I thought we'd just start with a question that came from one of our members. This is from Gillian, and again, I'm sure you're going to say there isn't an absolute answer, but love to hear what your thinking is. Gillian fractured her hip really end of last year, and although she's walking unaided, she really feels she wants to get back the strength in the affected leg, and wondered if you've got any tips or advice that you would give her. So it's about sort of ongoing rehabilitation, isn't it, really? I wondered if Katie, you had any thoughts on that.
Sure. So first, it's brilliant that that you're back walking unaided and want to take that next step. So well done on reaching that point in your recovery. When it comes to strengthening, again, it takes time. So really, my best advice is to do something that you previously enjoyed, as you're much more likely to stick with it. So if you were a swimmer, try to get back swimming, a gym goer, try to get back to the gym. You mentioned that you walk, then maybe thinking about picking up the pace to a brisk walk. If you do want to take on something new or something that would be maybe seen as higher impact, then I think it probably would be good to speak to a physiotherapist for a discussion on tailored recommendations for you. You can check with your GP office whether you can self-refer to physio or whether they need to submit the referral on your behalf. In some services, you can self-refer, and that would just give a little bit more personalised advice as to what exercises might be appropriate. But continuing with the walking, maybe picking up the pace would be a really good start if you want to get going straight away.
Thank you, Katie. And that leads actually to another question, which I'd like to hear from you both on, really, which is about do's and don'ts and this fear that when I've had an operation, what can I do? What can't I do after this particular one? I think, Celia, you touched on this kind of fear about putting your weight on your leg when you've had an operation. I just wondered if there's any sort of particular do's or don'ts or encouragement that either of you would give. I don't know if you'd start, Celia, with your thoughts about post-op.
Yeah, I mean, I think it's quite understandable that people are cautious about getting out of bed and putting their weight through what has been a painful injury. And obviously that injury has come about after a fall, and people worry that might happen again once they're upright. But in actual fact, you know, the bits of metal that the surgeons put in order to fix these fractures are very robust, and you put the same strong bits of metal in somebody who might have played rugby for England as you do in somebody who weighs 40 kilos who might be a frail older lady. So actually it is designed to be able to take all of your weight absolutely straight away after that hip is fixed. There are only very, very rare instances where that's not the case in terms of the different fixations that are used. So you are what's called fully weight bearing from as soon as you wake up after an operation. Katie, you probably want to say a bit more about the do's and don'ts.
Yeah, I suppose, I mean, Nick, you've said it very well. I guess the other thing is that in the past, people might have been told not to bend their hip too much or not to twist it too much. And a lot of those recommendations are kind of gone now. But if you do have any restrictions, you'd be told about it in the hospital for those rare cases where, you know, there is an issue around weight bearing. But if you haven't been told, then no, there shouldn't be any restrictions on movements that you do or how much weight you put through the leg. What's important is to get going and to do as much as you can do.
Lovely. Thank you. So just going back a bit, there's a few questions sort of earlier in the experience, I suppose. A question about pain, really. How painful is it after the operation? You talked about the possibility of nerve blocks, Celia. I just wondered, how much pain do people tend to have? People worry, are frightened, maybe on behalf of their loved ones if it's not there.
So breaking your hip is a very painful thing to experience, and that's why people need to come into hospital and have it fixed. So actually one of the reasons why we operate on broken hips is actually to alleviate pain. And that is why we might actually operate even on the frailest people, because they're in pain, and actually doing surgery is a way of managing that pain. And that's a very important thing to acknowledge. It's a pain relieving intervention, the surgery. So immediately after the surgery, often a nerve block will be given during the surgery itself. So the leg will still be numb to some extent for some hours after the hip has been fixed. Usually by the next day, that numbness or pain relief has sort of worn off. And then we usually give regular painkillers, at least for the first few days. Now, it depends on what type of operation you've had as to how much pain you may experience. Something like the hemiarthroplasty that I described, the half hip replacement, often we get away with just giving people regular paracetamol and the occasional extra painkiller if that's necessary. If you have had to have an operation that is more invasive, for example, if you've broken the kind of shaft of your femur, then you may need to have some additional painkillers over and above paracetamol, such as small doses of oral morphine liquid or little codeine tablets. But we tend to try and minimize how much of those people have, because they can make people feel a bit sick, which we can also do something about, but they also cause constipation. And almost everybody's bowels will go to sleep after a hip operation, partly because of the anaesthetic, being stationary, not eating and drinking, etc. So we have to get everybody's bowels going again after a hip operation. And that's why you'll find that you're almost inevitably going to be given some laxatives. They don't work immediately, so don't get anxious about that. It's a slow process, but that's why we have to balance painkillers against bowels a lot of the time. Because the painkillers will slow your bowels up.
Great, that's all very clear. Right, let's move on a bit now. There's a question here.
Well, just if it's okay, I'll just add in about the pain. You know, as well, experiencing the pain and then the idea of getting up with physiotherapy in the hospital in the early days. So it is something that is timed. So if you're on a pain management regime, it's timed so that physiotherapy will come once your pain medication has kicked in, so that you're in the least amount of pain as possible when you're going to start moving. So just that is considered by the rehab team.
Yeah. So we give the painkiller in the morning, and then the physios come along soon after that once the painkiller's kicked in, for example. But then the painkillers get weaned down over the course of the first few days, really, after a hip fracture. Often people are discharged not on any painkillers at all.
And you both talked about all the different professionals who are going to be helping you during your time in hospital. One of the things I was thinking is obviously you talked about physio and OTs, but if you're worrying about what's going to happen to your mum if she can't manage at home, you know, that kind of next step, if there have to be decisions there, is there one particular professional in the team that does that, or is it going to differ? You know, the discussion about maybe having to move into a different setting when they leave, or getting that kind of extra care, sort of other social care aspects. Who would you talk to about that in the hospital, or would that vary?
So the primary person who has oversight of that is the occupational therapist, but in reality it is a team working together, because each member of the team will gather different aspects of information that feeds into that decision-making process when somebody leaves hospital. So it may be the consultant, it may be one of the junior doctor team, it may be the physiotherapists, it may be if somebody has a dementia, then actually a dementia care person within the hospital who may actually know the patient from previous admissions, for example. So it does vary from hospital to hospital, but if you're stuck, then the most sensible person to try and get in contact with is the occupational therapist on the ward.
One question was about strengthening bones. Actually, you've touched on that because you've talked about getting active again, but you've also talked about medications to strengthen bones. Anything else you want to add about, can anything be done to strengthen my bones so this doesn't happen again? I think that's probably covered, isn't it, by your mentioning of tablets or even a little infusion, little drip to strengthen the bones.
Yeah, I mean, actually using your bone is one of the best things you can do to keep it strong. So putting weight through it. You know, if you take to your bed and you never put weight through your bones, then your bones will get weaker and weaker. So it is really important that you load your skeleton for your skeleton to stay strong. It's also important that you eat well, and that often people have to take calcium supplements or vitamin D supplements if calcium isn't rich in the diet already. And then things like alcohol and smoking are best avoided because bones don't really like an alcoholic environment. But I think the other thing to say is about medicines. So there are now a whole array of different medicines that we can choose from to find the right treatment that best suits a given patient. And that includes tablet-based treatments, and they're frequently the ones that you take once a week. But there are also injection-based medicines, and there are a number of those as well now, which can be provided, particularly if certain people can't take the weekly tablets, for example.
Yes, and I think just to say, we've got lots of information on our website about those drug treatments if you want to know more. Yeah, very basic question here, maybe Katie, when can I go back to driving? So you were saying this is very individual, but we do get asked about going back to driving after something like a hip fracture. Anything you want to mention?
Yes, I mean, we touched on this before the call started, I guess, and maybe the recommendation is at least 6 weeks, but it is kind of a very personal decision. And there was a suggestion of getting in the car and imagine you're doing an emergency brake and whether or not you feel able for that. But I think Celia, you'd mentioned that at least 6 weeks is what you would recommend to somebody, and then kind of going from there.
Yeah, I think so. I think because people's recovery trajectories are so different, there is no one size fits all. I think most people will take at least 6 weeks to be able to get sufficient function back. At the end of that 6 weeks, you may still be seeing a physiotherapist through your community rehabilitation, and that's something that you can then talk to that physio about, because they will be able to objectively assess you at that time. If you've been discharged from the community rehabilitation, then it's quite reasonable to ask a GP that. So general practitioners are very good and often have to review driving restrictions for lots of different conditions. So yeah, that would be a reasonable thing to ask your GP.
Thank you. And what about a follow-up appointment? Do people get an outpatient appointment to go back and see the team? Is that something that still happens after a hip fracture?
So follow-up is variable. Often some people aren't followed up at all. It depends on the type of operation that you've had. For certain types of operation, the surgeons will want to see you in their fracture clinic in, for example, 6 weeks' time. But for some of the fixations, they don't require that. It would be written on the discharge summary when you leave the hospital what the plan is, if that's necessary. The other thing that can happen is that if it's judged that you do need a treatment for osteoporosis, as many people do, but it hasn't been able to start you on that treatment whilst you're in hospital, then you might need to come back to a clinic in order to have either further assessment or to start a treatment, for example, if it's an infusion-based treatment. So that's another relatively common reason for coming back into a hospital environment after hip fracture. The other circumstance is that when you're in with a hip fracture and you get looked after somebody like me, we tend to look at all of the systems, and it might be that we find something else, another diagnosis of another condition. And if that is the case, then we may well refer you to another pathway to see another ologist of some description according to whatever it is that has been identified as being needed.
Katie, I was just interested, I really liked what you were saying about people being frightened and fearful and the need to encourage them. And you talked about people avoiding, it's very common to feel like you could. I just wonder if you could say a little bit more about that, because I thought that would be really helpful for people who are, fear is a big thing, isn't it? When you break a bone, that's going to happen again.
Yes, and I suppose, going back to what Celia said, for a lot of these people, it's that they had, they fell from a standing height just on the floor in their home, and then had such a big injury and needed such a big surgery and had the pain afterwards and went through everything that they go through, which is unplanned, unexpected, and it's a lot to absorb. So it is completely natural to feel frightened about that happening again. And for a lot of people, they'll acknowledge that they're feeling frightened, but they continue on because they say, I'm frightened, but I have to do my shopping, or I have to do this, and then they just continue on. But there is people who are frightened, so they maybe step back from doing what they were doing beforehand, even though they might be able to. So it might be a case that, you know, you're walking really well in the hospital with the physios, just using a stick, and then you go home and you avoid doing that walking with the stick because you're a little bit frightened that you might fall again and break another bone or break another hip. And it is this kind of catch-22 or a dilemma, because by avoiding moving, you're going to get weaker. So your muscles are going to get weaker, your bone isn't going to get better, and you're actually going to be increasing your risk of having another fall. So you're better off to keep moving and doing as much as you can that has been recommended by the physiotherapists in the hospital while you're waiting for physio in the community. And then when you're seen by the community team, you know, having a discussion about, you know, how you're feeling, and if you are feeling afraid about falling again, and you know, just to get some reinforcement about what you're able to do and that you are able to do it. And also to give your family members that reinforcement as well, because I think a lot of times as well, it can be that, you know, if you see a parent who's had a fall and broken their hip, that maybe you would like them to stay put and not move because you don't want them to break their other hip. But actually, it would be much, much better to encourage them to move and give them the confidence to start moving again, because they're actually, one is worse than the other. So moving is what's advised, in keeping with what's been recommended by your rehab team, to do that as much as possible and safely.
Sort of kind, supportive encouragement, isn't it, really? I think that's really helpful advice.
Yeah. I mean, just to follow on that, I mean, I very much agree with what Katie said. I mean, quite often I find myself talking to patients and saying, you know, you're going to have to push yourself a bit. You know, it is hard work. It doesn't just come back. And the more you put into it, really, the more you're likely to get back from that investment. I mean, that's the same as any physical activity, whether you're in your 20s. You know, the more exercise you do, the fitter you're going to be, and the better you're going to feel. And that doesn't change as you get older. I think the other thing I just wanted to say was, which I see quite commonly, really, just reflecting on what Katie said, after about day 3 or 4 after an operation, quite often people get a bit tearful in hospital, and that's really because there's a sort of realization after about 3 or 4 days of quite a lot of frenetic activity and you know, an operation and all of the aftermath of that the dust sort of settles and people realize, gosh, you know, look at how much has changed. And they get upset by that. It's totally natural and normal, and I'm sure I would be in the same, I'd have the same feelings in that position. And then what you see is, after a few days, people start to do more, and they start to feel a bit more in control of their own bodies, and that upset begins to settle. But it is quite normal to be upset in that first week in hospital, having gone through all of this.
Thank you. And I think it's just knowing that's really helpful for both family and the person affected. So thank you for that. Well, we're nearly at the end now. There's so many other questions I could ask, and we haven't got time, but this is a bit of a particular one, probably for you, Celia, but I think we do get asked about this, and it's, what's the difference between a hip replacement and an operation to mend a broken hip? And just a little bit of clarity there, I think, would be really helpful.
Yeah. Okay, so there are two things. One is people can have osteoarthritis, which is a disease of a joint. And when it's severe, you have to replace that joint by doing a total hip replacement. And when you have a total hip replacement in that scenario, you are at home and you choose when you're going to have that operation, or the surgeon and so on. It's planned. You come in and you're well, and then you have an operation and you're able to then get out of bed pretty quickly. And people are sometimes only in hospital a day or two for a total hip replacement, because it's all planned. In the context then of hip fracture, so that's a break through the bone, and there's trauma associated with that. As I said, it's sudden, it's an emergency admission, and it's unplanned. which means all of the other medical things going on that a person might have about heart disease and lung disease and diabetes, none of those things have been sorted out necessarily in order for that person to be ready for that operation. But nevertheless, you've got to get on and do a quick operation. And only in a very small percentage of cases will you actually put in a total hip replacement into a broken hip. The vast majority are the types of other operations that I described there, either a half hip replacement, a dynamic hip screw, or the other one is where they put a nail, a long rod through the middle of the femur. Only in a small number of people do you actually do a total hip replacement for a broken hip. In that instance, in that case where you do a total hip replacement for a broken hip, then actually the recovery is longer than in the case of when you've chosen to do it for arthritis, because of all of the other tumult going on around the time of that broken hip. So I often hear this, and people have a perception that, oh, well, they had a hip replacement and they were out in 2 days. Yeah, but that applies to the scenario of arthritis. It doesn't apply to hip fracture, where there is more to sort out and the recovery takes longer.
A really useful detail, I think, and thank you for explaining that. Well, I am going to have to bring this to a close. We could go on, but sadly no time left. So thank you both so much for sharing all your knowledge and understanding, and thank you to all of you, our audience too. Before you go, 4 quick points I wanted to make. First, do look out for some follow-on sessions we're doing. There will be a Bone Matters Extra on this same topic quite soon, and we are also going to do a session in September on keeping steady and ways to help prevent you falling over, so about sort of what's called falls prevention, because we know that's important too, so look out for that. Do check the resources below. We're pointing you to lots of other things to read, which I'm sure you will find helpful. Give us your feedback. And finally, we do have a new option, which is to sign up and get alerts to find out about Bone Matters sessions in the future. So do look out for that too. And thank you to everybody, and goodbye.
Thank you.
Thank you.